Affordable Care Act has introduced a number of provisions that have expanded insurance coverage. For example, the Medicaid expansion. There are new insurance standards according to the Affordable Care Act. Individual mandate was there to have the insurance, but now it has been repealed. Now, people are not mandated to get insurance anymore. But there is the online exchanges, health insurance exchanges that were established to make it easy for people to buy insurance. They were both at the federal and the state level. It is also called as the HIEs. 12 million people bought insurance as of 2018. Companies post their rates on HIEs, and it is very easy for people to buy them. Medicaid expansion was expanded to allow individuals with household income less than 138% of the federal poverty line to be able to be covered under Medicaid. Price transparency says that the transparency of the prices should be there, and the providers should be able to let people know what prices they are going to charge. High deductible health plans also came as a result of the healthcare reform of ACA. And with that, the rate of enrollment has doubled since 2009, where you have a low premium and high deductible account, but then you also get an HSA, you get the health savings account if you purchase the HDHP, which is the high deductible health plan. Basically, what it says is that unless you meet the deductible of $3,000 or $2,500, the insurance is not going to kick in. So people are very cognizant of the way they spend. That is a very good way of combating moral hazard that we discussed earlier. And with ACA or the health reform, there is an increased focus on chronic care. So if you have chronic issues such as hypertension, blood pressure, diabetes, and so many other arthritis and other issues like that, then you start taking care of yourselves early on, so that insurance doesn't have to pay huge dollars. There are some general reimbursement methodologies. Regardless of payer, there is a limited number of payment methodologies. The first one is fee for service, where payment is tied to the amount of services provided. If it is charge based, then it is you pay billed charges per the charge master. Cost based, only allowable costs are reimbursed. Costs are directly related with healthcare services, and there are also negotiated and discounted charges. A prospective payment says that rates are established before services are provided, per procedure, diagnosis, per day, and bundled payment. Capitation says that payment is tied to the size of the covered population and the number of enrollees. So you pay a fixed amount per covered life per period, regardless of the services provided. For the fee-for-service charge-based reimbursement, payer pays billed or gross charges for services rendered. Historically, all third-party payers reimburse providers are based on bill charges, and some payers still use bill charges as their payment method, but often they negotiate a discount from gross charges ranging from 20 to 50% or more. So, what should the uninsured pay for healthcare services? And that is a question that you should think about. Then the next one is the cost-based reimbursement. Payer pays all allowable costs incurred in providing services. Typically, periodic interim payments are made with a final reconciliation at the end of each year. Medicare uses this method for all hospitals in its early years. They used it from 1966 to 1983. Not so much used today. One example is Medicare payment to critical access hospitals. And prospective payment fee for service says that you have a fixed payment determined beforehand that is not dependent on either costs or charges. Prospective payment may be on a per procedure basis, per diagnosis basis, per diem basis, and bundled episodic pricing basis.